Okay, moving on, so we keep things rolling. We all know Dr. Jamie Hampton. We don't need to do much more introduction, except that she's awesome. Isn't she awesome? Now, why don't we give her a hand of applause?
You guys, come on.
Yeah.
Come on. Moses.
I put
He's
you on the
getting me back now.
But yeah, putting her on the spot for
Putting me on the
embarrassing me. Well, now she's going to be introducing bladder pain syndrome, so I'll hand it over to Dr. Jamie.
Thank you. So I think this is a really, really important topic. And first of all, I want to again thank you all. It's just been an amazing weekend, just hearing all the speakers. Those speakers are my friends and they're my colleagues, and I just have deep, mad respect for them. I really appreciate what they're doing for the profession. But, you know, again, you all being here in person is showing the dedication, showing up and doing the work. So I thought I want to do something that we see in clinic, believe it or not, a lot more frequently than what you think, because people don't talk about it, because again, this is one of those like persistent issues in your patient populations. But I wanted to take a little bit deeper dive in this particular topic, because I bet you see this all the time, and I want to put kind of like a face to what it is. So bladder pain syndrome has traditionally been called what you all know as interstitial cystitis. That's very, very rare to actually see somebody who has IC. Lynn, am I pointing towards you again? Okay, so we're just going to advance the slide here. Interstitial cystitis is, we'll talk about it through the slides, but you have to be diagnosed with what's called Hunner's lesions, and so they do a cystoscopy, and so they'll go in and they'll look at the lining of the bladder. But bladder pain syndrome is one of those things that can be post, you know, your patient has said, you know, she or he had a UTI. They were on rounds and rounds of antibiotics. It went away. Symptoms started coming back. They went back to their GP. Their GP did the urinalysis. Urinalysis came out negative, but they still have the same symptoms, you know, urgency, frequency. Let's pause there for a second. So if we have time, because I'm kind of like, oh, we should have done a demo. We're going to get to one of my most favorite things in the body, and I'm just wondering, it's a totally safe region for you all to needle in, so you don't have to feel like it's not a pelvic floor piece of the puzzle, but it actually contributes to bladder issues, and it's great for urgency and frequency. If you all are open to watching me demo on someone and then y'all practicing, I think it would be really great. Are we okay with that? Yeah, we want to do that? Okay. And the other thing too is after this presentation, I segue into consent, because again, you're not going to be, you will be, but you'll have more tools in your chest if you actually, if we go over consent and how I approach consent with patients. One of the kind of, when people saw the original syllabus ages ago for the pelvic floor seminar, they're like, we don't need to go over the consent. Like, we have our own consent. It's not, it's a different level of consent. You're in a different world here when you're doing with this, dealing with pelvic floor issues. So we're actually going to go over the consent and how I approach consent in a very safe and neutral and non-threatening manner to your patient. Okay? So we'll segue into that, and then we're also going to do a draping demonstration, and you all are going to practice the draping demonstration as well, because one thing that will certainly put fear into your patient is if you're fumbling around with them, trying to figure out where to go and how to like navigate very, very sensitive areas of their body, right? Like, we don't want to put fingers where they don't belong. We don't want to touch things that we shouldn't be touching without them knowing about it. All right? Does that sound good? Yeah? Okay, good. And nobody has to get undressed, so don't worry. Okay, so this may be, for some of you, the very first time you've ever heard of bladder pain syndrome, because it's always been labeled kind of as IC or UTI. And one of my greatest joys is reconciling different ideas, because it's a challenge for me, and I really like it. It's like cerebral gymnastics. So how does that possibly relate to orthopedics, right? Like, because this is an ortho symposium, and you see bladder pain on there, and you're like, what gives? Why am I doing this like internal medicine stuff? But as you have learned and we've talked about, you know, pain is everywhere. It can be everywhere. It can involve peripheral and central. And I am hoping to provide you tools to actually work from the outside MSK to the inside, so that central sensitization. And so what exactly is bladder pain syndrome? Now, to me, it's never that simple. I always think like we have to go back and back and back. So if you can distill it to its actual essence, what exactly is pain? To me, that's more important. Like, I hear that it's affecting this organ, and it's impacting kind of geographically the area, but more importantly, having a really good understanding about pain and treating pain, to me, is what's going to give us a little bit more insight. You yourselves in your practice are probably very, very comfortable treating individuals who have pain from injury, post-surgical pain, or your garden variety musculoskeletal pain. But again, I'm here to tell you that, you know, everyone has pain, and we need to be actually changing the narrative around how we approach pain, how we discuss it with our patients, and, you know, how it impacts our treatments, essentially. Language is really, really important in clinic. How many of you have had patients who are like, oh, my headache was really bad this week, or oh, my back pain flared up, or oh, my XYZ? I'm always like, do you really want to have a headache? Like, is that really your headache, or is it just something that's really irritating and bothering you that you don't ever want to see again? So it's about kind of getting to know your patients, getting to know like how they're really like thinking about what it is to be in pain. And that really affects how we approach the situation. So here's just a really nice visual about your pain. I love it when a patient comes in and I'm like, okay, what can I help you with today? And they're like, I hurt all over. It's like, where do you even start? You know, I see a patient, one patient every 45 to 50 minutes, and I don't have all day to be working on all the different slings and all the different, you know, musculoskeletal and central nervous system. Like, I just don't have all day for that. It would be great, but I just don't. So we just want to be very systematic about when we're coming in, but thinking holistically around it. And I think that can be a challenge for some. And I think that it's important that we review what we're all up against. So, and coming face to face with our patients who are in pain, and what did I have here? Whether it's a great deal of pain or tolerable pain. So asking the right questions is super important here. Pain is complex and can be broken up into two very specific categories, and we must address both of these categories. Now, you heard Dr. Lombardi talking to you all about how, and actually Ariane asked about this, working with motor points and then people who have central sensitization. So he teaches this really elegant, simple treatment called perfusion. And do y'all know perfusion? Yeah. So perfusion is like segmental acupuncture for those of you who don't know it, and it's hooked up to frequency. So you'll use it to kind of like help with the nervous tonicity. So it kind of brings everything from a 10 down, 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 and it's very calming for the patient, and it's very, very helpful to kind of reset. So it's like I had some people who aren't familiar with it. anyway, it's really, really great. And these are the patients that you can actually use that perfusion therapy with. But so it's broken up into two, peripheral pain and central pain. And then we must kind of understand what that actually means. So peripheral pain, we all know is, I hurt my knee, or oh, my hip hurts, or oh, I sprained my ankle. But if it becomes a noxious stimuli and it doesn't get resolved and the gait is off or whatever, or there's been a fracture that hasn't been looked at and you're in a pain state, that's going to become centralized. And I liked that graphic for that. So this is a hard and fast review here, but what is nociception versus pain? So nociception is your body's danger scouts, right? They're looking for things that are going wrong. So it's like, if you're running away from a saber-toothed tiger and, I don't know, let's just say it reaches out and scratches your gastroc or your calf or whatever, and you're just so in the moment, you're not feeling that you've been hurt and injured, well, eventually the nociception is like, oh, there's an issue here. Like the brain has to do something about it, otherwise we're gonna die. So it actually reports, nociceptors report intense mechanical, chemical, or thermal stimuli through the afferent nerves. Afferent goes to the brain, efferent says, F off brain, peace out, I'm gone. It's mediated by both the central and the peripheral nervous system through beliefs, expectations, and behaviors. So we all have had patients who have, these beliefs that they're just never going to get better. Well, if you're never going to get better, why are you here? Like, why are you even trying? Again, I'm not a hand holder. I mean, I am when I need to be. But it's like, you got to really change the narrative here. You've got to break down the barriers with language, with patients. This next slide is actually just a really nice little graphic about how it works here. So you have the stimulus. So this is let's just say the saber-toothed tiger comes over and scratches you. And you have this sensory transduction region that says, oh, there's something going on here, and then it goes down the axon into the terminal, going up the spinal cord into the brain saying there's something happening. We need to check it out. Is this 911? Are we going to die? Now, if you have an insult to an organ like the bladder that gets resolved through antibiotics, but does it really? If it still has that noxious stimuli happening, it's never going to resolve. And so that's when we get into that brain looking for things. Patients have these behaviors. Again, this goes back to a couple slides ago. The behavior of looking for it. They're just like, oh, I felt great after my treatment, but then I thought, wow, I feel so great, I don't feel my pain. And then they're like, oh, there's my pain. So it's about breaking that cycle. And it's really important when you're dealing with IC, bladder pain syndrome, endo, those types of things. So pain itself is an unpleasant sensory or an emotional experience associated with actual or potential tissue damage. And it is mediated by everything internal and external. I was having breakfast this morning and was talking to my breakfast mates about how, your patient, you may get into an area of their body and they'll say, oh, for example, I was treating somebody who did not put anything on their intake form other than they had low back and hip pain. It was low back and right hip pain to be exact. And I was needling her junction between the superior border of the piriformis. And I hit a spot on her and she started crying. And I thought I hurt her. I said, oh, I'm so sorry. Are you okay? Did that hurt? And she just became like just sobbing. And she goes, "That's where I fell when he raped me." Yeah. So those things are internalized and they're stuck because that is an external to internal. And it's a muscle memory. And it's our job to help open up those lockers and clean them out. And I'm very passionate about this, as you can tell, because they feel better. Your patients feel better, right? You meet them where they are and you let them be who they are when they need to be. And you be who you are and they love you for that. But anyway, so the pain that she was experiencing actually here was also an internal pain, right? Yeah. So one of the things when we're dealing with pain is baskets. You can call it categories or however you like to think about it. But when you actually can categorize your patients who are coming in, it makes your job as a practitioner a lot easier. And for those of you who practice herbs and internal medicine, you will get this. And for those of you who maybe don't, you're going to get it easily too, because I'm going to help you understand. A great analogy is like if your patient comes in with migraine, for example, and they've had, it's hormonally induced around menstrual cycles, and then you have a whiplash patient that you're seeing who also has migraines. Like they're going to be in different baskets, right? So you have to kind of work separately with them, but do your thing, but work separately. And people ask me too, like, how do you know, like, how the flow of your day, like, how do you know to put people in baskets? Well, I do a lot of pre-screening before I even actually like schedule patients with me, because I need to know, am I seeing something that is going to require a lot more like mental bandwidth, or is this somebody who's just coming in because, I treat their partner for whatever that is, and then they may have like injured themselves. So that's one way to do it. But and this is specifically for you, Glenn. Glenn, we were talking about how to actually make the appropriate amount of time for patients. If you have those really difficult patients, your time is really valuable. So I actually, in the very beginning, because I had a busy clinic, I would put all my pelvic floor patients on certain days. And no one else was allowed to be scheduled during those days because I was charging more for it because it required a lot more research, a lot more emotional availability on my part. I had to be prepared for that. So I encourage all of you, if you decide to go down this path, to do the same thing, to really think about how you want to structure your interactions with your patients and whether or not, they're in an easier basket versus a more difficult basket, okay? But it's not a slurry together. Those practitioners who just do slurries and just, you're going to run up against big problems, like with the flow of your patients, also to your mental health. Like you saw me get emotional. I get emotional all the time. It's just who I am. But when I'm with a patient, I try not to be that way, right? But I can relate to you all because we're all in the trenches together working with these patients who really desperately need us. And, I know you all feel the same way I do. I do. I just know you do. So don't even pretend like you don't. So some of the baskets of pain can also include just emotional stress. You've got your patients who are, going through a really bad separation, who, might be financially strapped. Psychological stresses. So patients who come in with issues who, they feel badly because they can't have sex with their partner because they're in a lot of pain and they feel like they're. I have so many patients who think that their partners are going to leave them because they haven't been able to have sex. That's so stressful. To me, this is just me, but like I love my husband and I would never think about leaving him like thick and thin, right? But these people have these real life, in real time issues. So also these psychological stressors that can actually cue and trigger the issue. Remember my patient who was raped by the brother, who is still living at home? Like that's a big trigger. So they're going to go in another basket that's going to need extra support that you're going to need extra follow-up with. The trauma basket. So this can be a physical trauma to the area or an actual, violent assault. And all of your patients, well, not all of them, but a big chunk of them are going to have these diagnoses with comorbidities, especially if you decide to go down the rabbit hole of pelvic floor. You're going to see a ton of endo. You're going to see a ton of GI stuff. There's just so many different baskets. So to me, it's like, I guess I phenotyped them so easily, like it just like, okay, we need to do this. We need to think this way. It's just like when Dr. Lombardi was talking about the XSTOR scans, like the 9 things, like boom, boom, boom. You'll get so good at this. It becomes second nature to you when it comes to like giving them what they need and what you've seen over the years in clinic of treating pelvic floor issues. Okay, when you are able to get your patient in the right baskets, you're going to deepen your trust and relationship with your patients and building a really stellar network to manage patient care and expectations. I mean, I do feel, I bet you all feel like you're your patient's therapist too, right? I mean, they tell you everything. I feel like I would be a good hairdresser. Right? Because we just blabbed our hairdressers like, oh my gosh, did you hear about Louise? We become this like trusted confidant. And I mean, I know all my patients' families. I know what their favorite pies are. They don't like pumpkin pie, but they love apple pie and only deep dish apple pie. So, right. But it's important that you establish that trust. And part of the consent that we're going to go over is literally having neutral space for your patient so they can actually feel welcomed, they can feel safe, they can tell you, like they feel like they can tell you anything and everything. So that's a really great place to be in. Okay, so the breakdown a little bit further. Okay, so this is back to nociception itself. So again, this is brought on by potential tissue insult. It's caused by noxious stimuli in the peripheries, and it's continually maintained by the stimuli. So these are your bladder pain patients, again, who have had an irritated bladder lining, and that even though it's been resolved and there's no, E. coli detected or whatever, they're still feeling it, and it's just this constant feedback. The other thing too I want you to think about and talk to your patients about this, even if it's like a UTI, if it's just a garden variety UTI, if you think about the average length of a flaccid penis's urethra, you've got some length in that urethral canal, correct? That goes into the bladder. Now, a person without a penis, us ladies, we have a shortened urethra, so there's more vulnerability there to transmit any type of external pathogen into that urethra, into the bladder. So think about it again, like structurally. We have more of a predisposition to get urinary tract infections because of that, and we don't have that protective sheath and the actual, just the inches of urethra. And we all know, and if you all don't know this, but 80% of urinary tract infections are caused by E. coli. So we know that E. coli migrates from, after you toilet. And if you decide, like you shower in the morning and you toilet and then you go work out, or you're running around and you're sweating, whatever, that can migrate into, remember how big your pelvic floor is, your perineal region? There's not a lot of inches between your anus and the urethral opening. So we have a predisposition to it. So it's helpful that you tell your patients about, like, okay, just make sure if you're prone to this, that you're using, bidets, and you're using the handheld, I can't think of the word right now, but you squeeze them. No, it's a peri bottle, right? And you can just like clean the labia. You can hold the labia open and clean the urethral area after you've wiped, okay? Because you want to cleanse the area if they are predisposed to UTIs. So these are your patients who are getting them like several times a year. Right, so again, just to talk about the pain, because pain's really important. So the second type of pain that we're going to talk about too is inflammatory pain. So this gives the brain tissue input on the tissue's healing. So it's brought on by pro-inflammatory markers and chemicals with tissue injury, pathogens, nutritional issues, and the microbiome. It's perpetuated again by this continuous noxious stimuli. Inflammation remains as long as the tissue hypersensitivity lasts, which can be swelling, redness, pain, and itching. Then we know that there's neuropathic pain. So this pain is, again, it's a presumed nerve injury. It's maintained by increased excitability of those nociceptors and or the dorsal horn. So here you're going to be feeling spontaneous pain, electrical shock, dysesthesia, numbness, and tingling. And then this type of pain, which is functional pain. This is really interesting. So it creates limited activity due to the fear of pain. So you know your 0 to 10 patients that you say, 10 you're in the ER and you're on narcotics, and 0 you're nothing. But 5 is, to me, my 5 is, you love to play, I don't know, frisbee golf, but you're not going to do it today because you don't feel well, you're in pain, and if you do it, it's going to make it worse. This functional pain limits their activities of daily living. So could have relationships with the recurrent infections, diet, sex, heightened nervous system from traumas that have happened current or past, pain with the bladder or bowel filling. Some people, they don't ever, the reason why they're peeing all the time maybe is because, if they truly have bladder pain syndrome, when you have an empty bladder, the pain is alleviated. So they're peeing all the time because they don't want to be in pain. It could also happen with digestion and intercourse. So we know that there's very, very high prevalence. Again, I'm going to say this again, gastrointestinal issues, Crohn's, IBS, with bladder issues. Also, too, here's a little fun fact. The anterior portion of your bladder, the fascia that helps to anchor it to the pelvic girdle posterior to the pubis, is actually in both male and female. It comes out through into the labia, and then in men, right at the base of the penis, like your fascia comes out there. So you can see how it can be impacted by intercourse. Now, there will certainly be overlap between these categories, but when we're able to change how we view our patients' pain, we may be able to better serve them. Jamie Chavez had that really funny cartoon up today with the Vikings with the swords in the back, and they said, "No, I still have pain in between my shoulder blades." My patient base is never ever, oh, we're only going to work on this one thing today. Like, I'm only going to do, I don't know, like your lower abs. It's never that simple. I usually always have to work systemically and holistically. So I'll do back stuff, I'll do front stuff, I'll do, the pelvic girdle essentially. And I encourage you to explore that when you're in clinic with your patients as well, because it's really, really interesting. Again, he also articulated the fact about when you palpate the infraspinatus at SI11, you can feel it into that anterior deltoid, right? Like, you're going to find that a lot. And today when we do the demo with the urachus ligament, which is like one of my favorite ligaments in the entire body, a lot of times patients can feel it like in their penis, in their testicles, in their labia. Sometimes you can feel it in the vaginal canal if you're palpating hard enough. Okay, so let's go ahead and get started with bladder pain syndrome. Bladder pain syndrome, or here in the US, is called, have heard it called painful bladder syndrome. It's pelvic pain, pressure or discomfort lasting more than 6 weeks to months, worsens with bladder filling. So those are your patients who are always in the toilet because they don't want to have that full bladder. And it eases with emptying. It is a persistent urge or increased urinary frequency without identified bladder or urethral infections. We're going to talk a little bit about the anatomy of the bladder a little later on, but there was this really interesting urologist in Europe, actually, who got his license suspended because he was putting his patients on like a year's worth of really heavy dose antibiotics. And all of his patients went into an uproar because he was the only physician who's ever like helped them and actually made it completely go away. So they started to look into it. Anyway, they went to court. He got reinstated. But they said, that's really interesting. We're going to put patients on longer durations of heavy antibiotics and see what happens. And it definitely, there is definitely what we call it could be an embedded infection, because one of the healing mechanisms of the bladder, if there's an insult to the bladder lining, I love this. So we wake up every day to what? Live, right? Like we've already made it, like I'm living today. So our body is regenerating constantly until we die, we regenerate. So the bladder lining does the same thing. But back to this embedded infection, this really difficult to find embedded infection. So these patients who have embedded infection, these are the patients who the bladder lining sloughs off, so they have cloudy urine, like actually cells are breaking down and they're passing the cells. They were finding that their bladder lining, if your bladder lining theoretically is supposed to be like in a healthy bladder, like 4 to 5 layers thick, theirs was like 20 to 30 layers thick, right? So you can imagine all these like stealth pathogens. So for you herbalists, stealth pathogens, stealth, like to me, these are the Huang Lian, Huang Bai, Huang Qin patients, right? Like the patients who need like antibiotics. But anyway, so, but bladder pain here is seen as without identified bladder or urethral infections. Okay, so sensations of bladder pain syndrome can be any pain located in the pelvis. So your patients can say, it's stabbing pain. It gets worse and crampy with my menstrual cycle. It's burning constantly. It's throbbing. My urethra is spasming. My fellows, because do they have a longer urethra than my gals? They have a lot longer urethra, and they've got muscles in their penis. So, you know, they feel this spasm, which can cramp up the muscle, right? Like that's crazy stuff. So what you want to keep in mind is the complexity of the pelvis as a unit, and dealing with the viscera, the tendons, the ligament, the fascia, all within that pelvic girdle, because these patients are chronic patients that have been, again, I see the patients who just go through and through and through all of the GPs, all of the urologists, all the urogynes over and over again. They're the ones that it's impacted and affected all the different systems in the pelvis. You had a question? Oh yeah. Yeah, so the question was, do most of them, have they been on antibiotics? And what was the second part of it? Do I treat them? Okay, so I will treat them regardless, but I can tell you right now, the story goes like this. Bring, bring. Hey, this is Dr. Jamie. Oh, hey, this is Erin. Hey, Erin, how's it going? It's going really well, but I have this really weird pain that nobody can help me with. Well, talk to me a little bit about it. Well, you know, I had this thing, and you know, I had a new sexual partner, and I didn't, you know, XYZ, and then I went in and I had blood in my urine. Yes, rounds and rounds of antibiotics. They will have finished the antibiotics. The symptoms come back because of whatever reason, stress, you know, they just, whatever. It never really went away. They're usually on at least 2 to 3 rounds of antibiotics. So they've already been there, done that. So they don't, none of the doctors know what to do, which is why they send them to, oh, we got to look at the musculoskeletal component. You've got some MSK involvement. That's how they end up in my door. Well, and you also have this bladder lining, right, that's still causing irritation. Like if we're talking about the lining, that noxious stimulus is in there. It's making everything in this area cranky, everything. And if you think geographically, again, where's your bladder? It's right behind your pubis. Where's your, where's your, oh my God, your uterus? I was like, womb, what's the word for babies? Womb. It's right behind that, right? So it's like if you've got an inflamed, cranky bladder, what's it doing to your uterus? What's it doing to your vaginal canal? Like remember we talked about the Jell-O analogy about being filled with Jell-O? Do you all remember me talking about this yesterday? Like do I have space in here for rent? There's no for rent sign in here. I do not have vacancy in here. So, if you have an organ that's distended, like your colon, you're taking space away that doesn't even exist. So it gets everything angry. But you'll also see this, and just to kind of, because again, I'm organic and I like to have these real conversations. These are your chronic prostatitis guys too. They're just like, my prostate's fine, but it's enlarged and I'm having issues. Like there's just no space there. So it's our job to do what? Move out inflammatory markers, get that noxious gunk out of there so they can actually wring their pelvic floor, do their stretches, do their exercises so that the organ actually has space to move around. Your organs are supposed to move, right? That took me a long time to figure out because I just thought I'm just going to hang up my heart organ on the wall here and it's never going to move. It's just here, right? But if you're in an injury, like if you're in an accident and you're bucked off of a horse or whatever, you have to have some shock absorb. We're shock absorbers. That's what tendons and ligaments and joints are. Because if we didn't have those things, we'd die, right? Like our ribs would break, we'd puncture our organs. So it's the same thing with the organs themselves. The organs have to have a visceral movement. And I am very much into that. And what we do, you may not think that you do it, but if you do deep abdominal work, if you needle deeply in the abdomen, you're moving around viscera and you're affecting those, like the endopelvic fascia and the deep fascia in your abdominal cavity. Like that's really cool stuff. You can do that. Isn't that neat? I love that. But yes, I hope that answered your question. Anybody else have any other questions about that? Yes.
It's not about that.
Okay.
It's about, so have there been any studies on indigenous populations that maybe don't wear the same clothing, they don't have the same lifestyle?
I love that because you know why I love that? I was asked if there have been any medical anthropological studies about different cultures who may not be accustomed to Western garb, whether or not there's been studies on this. I am unaware of it, but given my background as an archaeologist and an anthropologist, that's fascinating, and I would totally do that if I had funding. Right? Like who doesn't want to go to some tropical place and just live there and, I don't know, study people? That's awesome. I don't know. Sorry. I don't know. But I mean, I will tell you this, your pelvic, this is me getting off on a tangent again, and I'm looking at you, camera people. We tell our patients, do we like them to wear synthetic underwear? Ew, no, right? Like our pudendal patients usually don't wear underwear. Our vulvodynia patients, we want them in cotton. We want them in organic cotton, breathable cotton, because we don't want to introduce these pathogens, this compromised geographical, dark, moist spot. We don't want that. We want airflow. We want it to be healthy. We want the tissue to be healthy. So to kind of jump back on that, that's really interesting because what do they have access to these the synthetics and the detergents and chemicals, and they might not have that. I don't know.
So my thought was if they're in contact with the earth more often, then they'll be bathed with the negative electrons, negatively charged electrons. And they have grounding sheets. Could they make grounding garments? where, you know, they just plug into the grounding outlet of the wall.
I'm in Silicon Valley. This is totally like I've got a startup idea, like to sell this thing. So did you all hear that? And maybe online it was about negative ions, grounding elements, incorporating it somehow in the garments that are closest to our mucosal membranes and our more sensitive areas.
And maybe being able to enjoy the benefits that an indigenous population would inherently have because they're in contact with the earth.
Yeah, no, I think it's a great idea. I think it's a really good idea. Okay, so let's continue on. Okay, so we all know now everything all together all at once, right? Bladder pain syndrome is the name that has most recently been recommended instead of IC. So that most recent recommendation came pre-COVID. It was like in 2018, 2019. The diagnosis of interstitial cystitis is for those who have diagnosed Hunner's lesions and who are symptomatic. And we'll talk about that in a little bit. What you're going to see now, though, is just out of ease of kind of research and all of the different healthcare systems like the NIH, the WHO, and what's going on elsewhere. We're kind of putting it into this IC BPS camp. So when you see that, you know that you could be actually reading about IC or you could be reading about BPS, okay? And it's just much easier since it's kind of hard to diagnose, and IC is not that prevalent. Originally, for years, pain in the bladder was given that generic diagnosis. So here's where this is important. We know now that bladders can have or cannot have Hunner's lesions and can be possibly non-infected or infected and symptomatic. So no Hunner's lesions, you can be symptomatic. Active Hunner's lesions, you can be asymptomatic. They were finding in a lot of bladders that there was, this is a really hard word for me, but I'm going to try and say it, glomurulations, which is basically irritation and bleeding. So it's on a scale, and I know that you all know, doing TCM and acupuncture, everybody's different, and everybody's scales of life are different, right? So these lesions can be, you know, a little bit of blood. Think of like, you know, so many parts per million or so many, you know, parts per, you know, milliliters or whatever, all the way to a lot. So wherever that dial is, but they're finding that you could have really, you could have Hunner's lesions and be asymptomatic. Okay, so here's what a healthy bladder lining looks like. Not too bad, right? Just catching myself up here because I have my speaker's notes here and it doesn't translate up there. Doesn't look too bad. So it's pale in color. You can see it's shiny. I always tell people that, you know, it's kind of like aloe vera on the inside. So it has that nice shiny coat. Here are varying differences in irritable bladder. So these are those glomurulations. And basically what that refers to is it's associated with, it's bladder hemorrhaging, basically. And in the presence of glomuralizations, or they're also known as petechial hemorrhages, it suggests that even in asymptomatic, that the lining is damaged, right? Sorry. So the comment was it looks very similar to endometriosis, right? I have a patient who's studying endo, like doctoral, postdoc stuff. And they told me something that really blew my mind. And we're not talking about endo here, but I'm going to tell you, because I think it might make a big difference in how you interact with your patients. They're finding that there's two different primary kinds of endo, and that one acts malignantly, but that is not a malignancy. So what that means is you'll go in and you'll have the endo cleaned out, and then it comes back with a vengeance and it gets worse. Yeah. I couldn't believe that. I said, oh my gosh, what happens to those people? And they're studying it, and they're actually publishing a paper on it right now. Like, they're in the works to publish this paper, because before it was just all endo was the same. Let's just go in and clean it out. But why did some endo come back even worse, right? Those are the types of endo that that are acting like super aggressive. Okay, so the question was, this is about endo. I'm not like, when it comes to the actual histology and stuff, I'm not I'm just not an expert in that. But is there a way to phenotype the different types of endo? They're working on that. Like, currently, this person is getting cadavers, not only cadaver, but also hysterectomy tissue. Like, they're getting whole uteruses from around the country right now to study the different types of cells and how they work. But there is currently no good, what's the word, like, reproducible way of knowing. But these people, like, I know you see patients who are completely, like, they can't have kids because they've had so much endo. Yeah. So this is she's commenting about how she's had 3 different endo surgeries, and how after the 3rd endo surgery, she developed fibroids. So this is one of those situations where you're not going to fix it because you're a certain type of, cellular, I guess the difference is in cells. Yeah, it's crazy stuff. I can't wait to actually read that paper. It's going to be really exciting. So here is actually really, really bad Hunner's lesions. So there's like no nice, pretty, shiny, there's just none of that here. It's all red and cranky and irritated. I mean, look at those, like, oh my gosh, that just screams painful. That screams painful right there. It actually shows up a little better on my slides. I think it's just the way that it's too lit up in here. So the pathophysiology of bladder pain syndrome. So there's that initial insult to the area, and it can be the bladder or not. But as a result to the initial insult, we see the developing of that central sensitization. So inflammatory, neurological, and endocrine changes happen. You can see patients who have autoimmune issues, abuse, rape, trauma. There's a strain and insult on the system here. Chronic threat responses become embedded in the area, and based on the threat, we see a massive upregulation of that inflammatory response, because it's a fire, right? The brain is perceiving it as a fire, and so it's trying to put the fire out, and so it's just this massive assault on the area. Whoops, sorry. So again, this is just to touch back. So for the sake of medical research study here, just remember you're dealing with ICBPS. I don't know, I think that. Bladder pain syndrome, though, is more than just an infection. As I had noted before, Hunner's lesions are not something that is seen regularly in urological clinic, but they can also be seen in asymptomatic bladders. I actually have a urologist at UCSF who I asked, I'm like, how often do you actually see these lesions? And they were like, oh, not very regularly. And that just kind of anecdotally was like, oh, well, I guess all the research that I've been, hearing about and stuff actually is right. When we see this, it's extremely rare, but we'll do see it, again, based on the criteria of, again, pelvic pain. Like, this is my world. Pelvic pain is my world. So I always think, is there bladder involvement? Is there bowel involvement? Is there, a visceral involvement on some level? Pressure or discomfort, again, lasting more than 6 weeks to months. Can you imagine if you had a cranky red bladder like that for over 6 weeks? How miserable. That's miserable. Again, worsens with filling, eases with emptying, persistent urge or increased urinary frequency. Again, no identifiable infection. Well, that leaves a huge field of patients that could potentially fall into this diagnosis, right? So some examples that I see in clinic are these. I see vulvodynia patients who have that. I see urgency patients. They might not have the vulvar pain, but they have urgency in conjunction with that. Prolapse. How many of you have seen prolapse patients? Yeah, prolapse. Because what is the prolapsed organ doing? It's prolapsing. Is it where it's supposed to be? No. Is it making the area cranky and crabby because there's no space in there, and then it's just like, it's like a bully. It's like pushing stuff out of the way. So back to this. So vaginismus. So vaginismus, for those of you who don't know, it's very, very hypertonic vaginal canal that's spasming, and they can't even put like their pinky finger in their vagina. I've had couples who have gotten married who they've never had intercourse, like never, not once, because it's impossible, it's painful. Persistent genital arousal. I think I'm gonna actually put that in my next class, in my advanced class, because I see that a lot. I know, right? Persistent genital arousal. Basically, it's like clitoridynia. It's a form of pain. I see it more so in my female population, where even if they have a little bit of friction on their clitoris or near their clitoris, it's very, very painful because the organ perceives it as, it becomes erect essentially, and it's very, very painful, and it's sending the stimulus, and it doesn't go away, like it's chronic and it's constant. Levator ani syndrome, I see this a lot in clinic. I probably see levator ani syndrome out of, let's just say, out of the week, I probably would say maybe 30 to 35% of my patients are levator ani syndrome patients. Urgency frequency syndrome, painful sex, I always have a hard time saying that, dyspareunia, chronic prostatitis, penile testicular pain syndrome, hard flaccid, which we touched about. Sorry, the slide got cut off. And then vestibulodynia. So the vestibule, for those of you who aren't familiar with vaginal anatomy, is the area around the opening of the vaginal canal itself. So when you do the advanced pelvic floor class, one of the things that we do is we needle around that and into the labia minora. I know, right? It's pretty intense. But like you would not do that if the vestibule was all super cranky and if it was red, like you remember those nasty hunter lesions, like it's that color red. Like it looks angry. So, but you want to make sure that you're observing before you needle. I just want to make sure I'm saying it all. So has a patient with vaginismus. How do I treat that? Do you get success with it? SSRI stuff, patient went off SSRI and it got worse? Yeah. Okay. Okay. So she had to keep going back on that in order to get treatment, right? Okay. So vaginismus is, yes, but it is a big commitment, but it's a worthwhile commitment because if you want to have a baby, if you want to have sex, even if you don't want to have, even masturbation, for example, you're going to want to actually work with a pelvic floor PT. One of their first things that they do is you work on desensitizing the area and using dilators. So they'll start with these dilators that are super duper skinny, and you have to make sure that they don't have like sensitivities or lichens or anything, because if you are introducing something like a lubricant that is unfriendly to the flora of the area, it can really flare them up. So it's a really interesting and kind of delicate, it's just delicate, but for what we do is we work on the nervous system. So this would definitely be doing lower sacral foramen, also too doing suprapubic work, adductor work, working your way into the labia majora, working on that. And then you gotta, one thing I teach in my class is your patient's tolerance level. And I also talk about that in the dry needling classes that I teach as well. Like if your patient is just like clamping up and, doing this thing and is resisting you, there's nothing good's gonna happen from that. So, but you definitely can work up to it. And yeah, you see results. I mean, I have a story for you. I don't know anything about that, yeah. I had a patient who had dyspareunia, which is pain with intercourse, and vaginismus. And I did the intake, I screened her on the phone. She was a referral. oh my God, this is hilarious. Actually, I tell this in my pelvic floor class. And she shows up, and she's this really, she's a lovely older lady who has never been married, wanted to get back into the dating scene. Do you remember the story? Wanted to get back into the dating scene, and she's like, well, I've had acupuncture, and you just sound great, and so, you know, I just want you to do your thing. And I was trying to coach her because in my consent and safe space and neutral language, she looks at me and she goes, could you just please stop talking? Like, I just want to have a nap. And I was like, okay, I see. Okay, you want a nap. You think you're going to get that here. Okay. So, right, it was crazy. So I'm draping her, and I'm moving the drapes, and I'm getting ready, and I go like right where I need to go. And she goes, what are you doing? And I said, well, I'm needling into your pelvic floor, and if you would have given me an opportunity to explain that, we would have had no surprises, right? And so, I know, right? And so she comes back the next week, and she goes, whatever you did was really helpful, and I swear to you, this is the situation I'm in like all the time. I did not lose my mic. Look at that. That was amazing. She brings out her bag, her purse, dumps it on the table, and there is an array of vibrators and dildos. And she says to me, this is what I'm using now. And she picks up this tiny little dildo. And then she picks up this thing that looks like a baseball bat. And she's like, this is what I want to get to. And I'm thinking like, okay, right? Like, we've got something to work for. Okay, we're good. But then I was thinking, I know, right? Functional goal, vibrator size, dildo size. But I literally was just thinking like that you're going to get cleft in twain with that size, because that is like humongous, like, oh my gosh. But anyway, so it's important to talk about that. But let's kind of go back to the vaginismus. She had that was a co-thing for her, right? Painful sex and vaginismus. And we got her better, and we got her active, and we got her like no problem. She was able to actually, she graduated from me, graduated from the PT, and kept on moving up in size. So, you know, the plethora of dildos and toys, yeah. When I saw her last, she was at the larger size. She wasn't at the like humongous behemoth size, but I was like, girl, you're good. Good luck. I'll see you later. But I'm sorry. She was about 59, 60. Sex is fun. Let's have some fun. I see a lot of people who don't fit the MS, they're younger. You know, I'm in the Bay Area, and so a lot of, first of all, actually, demographically speaking, I see a lot of techies. So I see people ages like 21 to, 60 who are still working. Half of my clinic is male, half of it's female. But I don't hardly ever see MS because, we know like what the diagnostic markers are for that, right? Like they're older, they're, Northern European descent. Like I live in a very diverse area, so I don't see MS too much. But I do see a lot of, undiagnosed like IBS, and that's when I'm like, you've got IBS, or I think you have IBS. You need to go get it checked out. I do see lots of stuff like that. Oh, did I repeat? So her question was, do I see patients with MS? Because she's seeing that in her clinic who have bladder issues, and my answer was no. So, okay, so how does this relate to my field, or better, your field of specialty? Well, it may not. I mean, this might not be something that you're into, but you might see. So it's okay. You don't need to be, you don't need to like dedicate your life to it, but I just want you to be aware of it. I want it to be on your screen and having been exposed to it. But many, if not all of these patients who have bladder pain syndrome have a mechanical component to them. And we all know here that that's what we do. We help with pain, we help with mechanical issues, we help with systemic issues. And we help them move out of pain. And this is a huge group of my patients, which is kind of why I'm passionate about this. I had something I was gonna say, but I forgot. So let's move on. The first thing to think about here is it's a diagnosis of exclusion, so like fibro. What does that mean? So the urologist, the urogyne, the GI must rule everything else out. And this takes on average 7 years to get diagnosed for BPS. 7 years. Somebody's got a cranky bladder for 7 years. Urethral burning for 7 years. They are wanting to find the toilet. They literally map out where they're going. Where's the toilet? Is there a toilet? Can I walk to that toilet? How long is the musical concert? Where is the toilet in proximity to where I'm going to be sitting? Their whole psyche revolves around mapping this out. And 7 years, you can imagine, I mean, I would just be, it's just terrible. Like that's just, to me, that's egregious. That's just way too long. The patient that's been through the pipeline, again, this is so applicable to pelvic floor stuff. These are your PCPs, your gynes, your urologists, your dermatologists, your pain doctors. I mean, a lot of the chunks of patients that I see now are through UCSF's pain clinic. They're through the urology clinic, they're through the general pain clinic, and then they're through the pelvic pain clinic. And that's really frustrating for them to have to like go through all that. And I try and be as fun as possible, which is why I have the gift of gab. But believe it or not, I'm an introvert and I like totally am quiet when I get home. I know it's really difficult to believe, but I try to give them hope. I try to like be friendly with them. I try to like have fun with them. You know, I want to be a light in their day. And a lot of my patients, I love them so much and God love them that they love me back. They're just like, I look forward to seeing you. Can you imagine having something for 7 years thinking like, oh God, I got to go to the, you know, XYZ again today. I don't have a good relationship with them, but then I get to go see Jamie. So I try and make it as fun as possible and as comfortable as possible for them. So in female patients, the pelvic floor, again, has 3 holes. So these are 3 distinct specialists. And our guys, again, have our 2. So urethra and the anus, and then obviously the vaginal canal for the ladies. But none of them are talking to one another. You don't see that until they get really far down the pipeline, and that's when they get into the pain management groups. That's when people start talking. And one of my goals is I want to be an intervention person. I want to just say like, look, I'm in the middle of the wheel and I have all these spokes around me. I want to be like, you need to be over here. Like I really believe in collaboration, and I believe that, I don't know, hopefully just forging relationships and alliances with these other providers, that I can get the patients out of that 7-year on average loop and get them treated sooner rather than later. So if you do, because again, I take phone calls, I have the luxury of, I live in the Bay, I get it. I charge quite a bit for my treatments because I'm a specialist and I love this, and I actually can dedicate and spend the time with my patients versus if you accept insurance and they put parameters around how many treatments and all this stuff. Like I have the luxury and freedom to treat how I want to treat. I don't like to be a caged bird. But when I have that initial conversation, you just want to make sure that you are asking them questions and that they've actually been evaluated, so with a proper evaluation, so you can rule out cancer. You don't want a patient to come in who has, malignancies and then you're just missing it, right? So the question was, Adrian asked what types of cancer. It's really any cancer that lives in the pelvic floor. But particularly if they come in with bladder issues, you're going to want to look at prostate cancer, right? You're going to want to look at bladder cancers. You're going to want to look at, we know that ovarian cancer, for example, and cervical cancer, it's all down there. The bladder is right there. So if you've got bad stuff going on, if you've got really, inflammation and pressure, that's a really great question. You definitely want to make sure that your patients are being screened for those things. I think I saw another hand. Was there not another hand? No? Okay. I so appreciate you all after lunch that you're still awake. Literally, thank you for hanging in there. So since there will be concurrent issues with bladder pain syndrome, this kind of talks about keeping your eyes open, keeping your ears open when you're doing your assessments and you're having those conversations to make sure that you're not missing something, right? So noticing other symptoms involved. Keeping your ears open, so your patient's telling you what's wrong with them and how you can help them. I always think that that's really important. Again, going back to that trust issue. Who was it we were talking about? The patient was saying something about diarrhea. Who was that? Who was that? One of you approached me and said that the patient was complaining about diarrhea and that it actually, oh, right. So so they had diarrhea, but then, so she's coming in for diarrhea. Then she saw the chiropractor. And then there's no bowel control. So is that diarrhea or is that no bowel control? Big difference there, right? Huge, huge, huge difference. So, dig deeper. Ask like really specific questions. Oh, that's right. And she actually had a bicycle accident, right? So could that be like nerve root issues, turning off the pelvic floor, affecting the external and internal anal sphincters? Yes, it could be. Can we help that? Yes, we can. Keep your mind open. Just because you're a back and neck person, or as Jamie Chavez is obviously a shoulder person, we can actually really successfully treat pelvic floor issues such as bladder pain syndrome. And if you've ever worked with patients who have chronic regional pain syndrome, it acts like that. And it's not simple, right? It's a complicated thing, but you can still get results. Oh, one of the other things I put in my notes, because I'm kind of a little bit ahead of myself, is make sure that you're asking questions about and don't put words in their mouths. Do not put words in their mouths. If they say they have pain, you want to kind of get down to like, what is your pain like? Or what is the pain like? Did you hear me switch the narrative there? And then they'll say, oh, it's this. Okay, well, when is it worse? What's your trigger? So it could be certain foods. Like we all know that there's an IC diet, right? The people that I see who have had interstitial cystitis, they're like, oh, a big chunk of them, the diet makes no difference. And if you're unfamiliar with the diet, it's basically like no acidic foods, no tomatoes, no alcohol, no coffee, no chocolate. What is it? No grapefruit juice. It's like stuff like that. But then there are a handful of people where they're like, oh, I had one glass of red wine and my symptoms flared up. So they're going to go in a different basket. Remember our phenotyping baskets? They're going to go in a different basket. Okay, so, ooh, I'm way behind. Okay, so we all know how to do E-stim, dry needling, TCM. I used to do a lot of herbs. I had a humongous herbal clinic, but guess what? I don't like it. It doesn't taste good. It made the house smell. And I was like, you are wasting your money. You're wasting your money. You're not compliant. I don't like this. So I don't carry any herbs now. I will prescribe herbs on very, 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 very rare occasions. I'll prescribe herbs. But this is a good opportunity for you all who are practicing, herbology to definitely Like these people need a lot of support. And the other thing too is, oh gosh, you got those patients who are literally, they have a laundry list of medications that they're on. Like right now in my life, I don't have time to look all that up. I just don't. Drug herb interaction, I'm like, I don't want to, I just don't. So I just don't. Okay, who gets bladder pain syndrome? We know patients are in their between 20s through their 60s, ties into visceral issues, also possible reproductive issues like endometriosis, sexual encounters, so that can be with STIs, or physical traumas like rape and abuse. Also too, just trauma to the region. Like if you fall and you hurt yourself, you're more likely to get it if you are female, and the ratio is 10 to 1. 10 to 1. Do you think that has to do with the fact that we have a shortened urethra? Probably. That microbiome down there is just spilling out, and there's no protection because we don't have a long hallway to get into the fortress. We have a shortened hallway. This is what is crazy. 0.5 to 30% can get bladder pain or generic reported urinary pain or pelvic pain. So think about how many people you see a week. Well, 0.5 to 30% of those people at some point in their life have had issues revolving around this. I have a question because I'm really bad with time. How much time do I have? We got a boogie, kids. Okay. You see, I talk a lot. Sure. Yeah. Ketamine. Of course. Yeah. Yeah. So the comment was, and I see a lot of patients who are on ketamine therapy because I do pelvic floor pain. Ketamine can actually insult the bladder, and it can cause bladder pain. Thank you for adding that. This is a huge issue, but where are patients? Why aren't we seeing our patients every single day in clinic? We're going to explain that, but we want to make sure that we're treating appropriately and based on the entire person. If your patient not only has bladder pain syndrome but pain elsewhere, we know what helps to mediate the pain and can work effectively to improve our patient's quality of life because they have really reduced quality of life. Pathophysiology, I'm just really going to go fast through here because I totally want to get you guys needling, but I don't know that we're going to get to it. I'm in big trouble. I'm so sorry. Pathophysiology, there's an initial insult to the area, can be on the bladder or not. It results in central sensitization, inflammatory, neurological, endocrine changes, autoimmune disorders. We saw that. Okay, so actual changes in the GAG layer. So that's the glucosaminoglycan layer. It's chronically inflamed. And basically, I'm just going to explain this really quickly. Your urine, if you have an insult and your urine becomes toxic and it starts to corrode, like acid would corrode, or base would corrode that lining. And so the lining gets thin and the urine actually can penetrate into that bladder wall, causing this irritation and the glomerations. So here's the upregulation of the C fiber afferents. And here's just the wiki about what the, so it's the nerve fiber in the central nervous system and peripheral nervous systems on unmyelinated with low conductivity, blah, 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 blah. Anyways, it goes from peripheral to central. That's what you need to remember. Okay, sacral plexus is also insulted here. And then when you get that, it's just going to cause the circuit board in the pelvic floor to go haywire, and you're going to start to see pelvic muscle dysfunction. And then we can just buzz through this really quickly. So here's, again, what's being insulted. Again, the pathogen causes inflammation in the gag layer. Lining gets worn, holes. The patient's sub and urothelium activates the C fibers, so it's nagging, stabbing pain. We talk about TRPV1 sensor receptors actually are the ones that stimulate the C fibers. The bladder's broken up into regions, the DAOM and the trigone. The trigone's at the bottom. Where does the water accumulate in a bowl? At the bottom of the bowl. What is your bladder? It's a water balloon, so it's going to accumulate towards that trigone. There are more receptors down there, okay? So the detrusor muscle, who's heard of the detrusor? Good job. Okay, who's heard of the cremaster? Yeah! So the detrusor muscle is, yeah, it's one of my favorite muscles. Look at that. The detrusor muscle is, if you've got your water balloon and you dip it in chocolate, it's the chocolate coating. It's that hard candy coating on the outside of the bladder, okay? So if you have inflammatory, angry insult on the inside of the bladder, because the bladder lining is all cranky, right? You're going to have some outside stuff going on here. So the detrusor actually can become spasmodic. So if you've got a spasming detrusor squeezing and you've got no space on the inside, that's a recipe for disaster right there. So you hit this, so the bladder, when filling without lining inflammation, will have a healthy manner fill and expanding, hitting a critical point that signals to the brain that it needs to empty. But if you don't have that expandability and the relaxed detrusor muscle, the bladder can't fill up to hit that critical point. So the bladder lining is hitting up against the detrusor, telling you have to go to the bathroom all the time.
Does the detrusor have stretch receptors in it?
I have no idea.
Oh.
I don't know. I'm not that smart. We'll have to look it up. Maybe I am that smart. I just never bothered to look. So you've got an angry, thick, inflamed inner bladder wall. The detrusor gets activated prematurely, so it supplies these forces, and you have an anxious and unhappy bladder. That's all you need to remember there. Are we okay that I'm going through this quickly? Okay. I don't want to... I know, the needling, right? Okay, so we're going to skip through this, but it's people produce more cortisol and adrenaline, or sympathetically driven nervous system will have a concurrent increase in level of inflammation. So higher stress, higher inflammation. That's what we need to know there. I just want you to always have this singed into your mind, the role of the pelvic floor, because it has a lot of different roles in our life. Autonomic issues, so here we see myofascial pelvic pain, autonomic neuropathy, sympathetic vascular dysfunction creating local muscle disorders, swelling and edema, so you can't achieve the full range of motion. Bladder pain syndrome, you have diminished vagal nerve function. So vagus nerve, main nerve, provides parasympathetic activity to organs. The small periaqueductal gray area in the brain helps to organize those descending inhibition responses, but it's going to be, right? If it was working effectively, it would be bigger, but it's diminished in people who have this issue. Visceral overflow, so localized nerves share function, organ function, and visceral with muscles of the local area. So if you have a patient who is chronically constipated and who strains all the time, there's a very good chance that they're also going to have issues with the bladder. We don't actually know why this is happening. There's so much I don't know. I wake up every day and I'm like, I don't know anything. Like, but that's kind of a good place to be, right? It's freedom. It's freedom to learn as much as possible, and I don't really put parameters on what I read. I just go down that rabbit hole a lot. So it could be correlated with panic and anxiety disorders. Well, I would be panicked too if I had to go to the bathroom and I didn't know where the bathroom was. That's just not fun. Chronic pelvic pain, depression, migraines, people are more likely to have those who suffer from bladder pain syndrome. And we're figuring out that there's an immune function component, which I think is really interesting. Treatment, working the big picture. So we're going to get into this. So look at number 2. Assess the pubic region, the pyramidalis, rectus, abs, obliques, TA, and adductors. Deep palpation can trigger pain and urgency, and you always want to treat what you see. So the pyramidalis muscle, who here has needled that and knows what that is? You have learned 3 things from me this weekend. Thank you. This makes me happy. The pyramidalis muscle actually zips up the linea alba. So it's a pyramid muscle that's at the base of the pubis. The apex of it is midway between the umbilicus and the suprapubis, okay? Now, there's a direct correlation between the pyramidalis and the adductor longus tendon. So you have to do the adductors if you're doing bladder stuff. And your patients will feel so much better after you do it. Here's a picture of the pyramidalis. I love these really old, I love those old pictures. And then the urachus ligament. This is what we're going to talk about. This is what I want to demonstrate. How are we doing, Lynn? Okay, wow, we covered a lot in like 5 minutes, right? Okay, so the urachus ligament attaches the bladder to the umbilicus or umbilicus. It's the remnant, so it's a vestigial remnant of the embryological umbilical vein from you to your mother when you were in utero. Here it is. We all know the rectus abs. Just know this here, that assists in compressing the contents of the abdomen. So if you have patients who are like hell-bent on doing crunches every single day and they've got overactive bladder and urgency and they've got bladder pain, do you think that that's impacting it? 100% it is. So you want them to do the opposite. You want them to do cat-cow stretches. You want them to do cobra stretches. You want them to do bridge stretches to lengthen and soften the rectus abs to alleviate pressure around that area. The rectus sheath itself is a multi-layered aponeurosis of resilient fibrous compartment that contains both the rectus abs and the pyramidalis. So if you don't have time to go to the pyramidalis, if you do any ab work, you're going to be indirectly affecting the pyramidalis. Just FYI, 20% of patients don't have the pyramidalis muscle. Just some information. The detrusor, so sometimes it can just be as simple as the detrusor. So here we talk about the sphincters. You've got 2 sphincters, the urinary sphincter, the internal and external. But if you've got spasms of this, interesting that it can lead to diarrhea and dysmenorrhea. But one thing I just wanted to add is you can have an overactive detrusor muscle that causes urgency. Because what's it doing? Squeeze, 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 squeeze. You got to go pee, you got to go pee. That's what it's telling you. And then, okay, so here's the perineum. I just want to show you how everything is all intertwined. The bladder sits immediately above and anterior to the vagina. Pelvic floor hammock, we needle this in my pelvic floor class and learn how to navigate the geography of your patient in my class there. So peripheral and central. Pain may or may not be coming from the said source, right? So you just want to establish with your patients to understand exactly what the issue is and how you can help them and where it's coming from. Bladder diaries, this is really important. I have my patients keep diaries of everything. Even if it's just a Post-it note, I don't care. I want information. The more information you have, it lets them see what's happening. The more information they have, they can actually understand their triggers and how they can help themselves. And you want to make sure that they do, you know, scale of 1 to 10 or however you want to number that. And also, is it burning? Is it stabbing? Did it go from stabbing to burning? When did that happen? Also, too, if they can take a volume of their urine throughout the day, like if they work from home, they can have a little cup, a measuring cup. You want to know, like, is the volume, how does that play into the bladder emptying and also the pain levels? It's for everything. You just want to know. You're not going to know if it's just detrusor. We do know that the detrusor will spasm for sure, but you're just not going to know that. Okay, so central sensitization. Here you're going to want to do electroacupuncture. Again, perfusion treatment, segmental acupuncture is very, very helpful. And this is just to show you what's happening in that nervous system. And then the vagal tone, one of Anthony's classes a really, really long time ago, I told you yesterday, use the hot water bottle on the sternum. That helps with the vagal tonicity, and it brings it down. So it takes the slide from a 10 to a 5, okay? Also, you can put the moist heat suprapubically. And then I don't think we're going to get to consent today. because I really want to show you, and I want you guys to practice. How much more time